Aesthetic breast surgery, session 6, breast reduction inferior pedicle technique. First, we have to say that the ideal breast reduction technique would allow for reliable and consistent transposition of the nipple area complex. It's a very important issue you have to consider. With preservation of nipple area viability, sensibility, and lactational potential. So the ideal technique will also be applicable to all breast sizes. The advantage of the inferior pedicle is suitable and safe for larger reductions, and it's also a reproducible technique. I have to know the vascular anatomy of the inferior pedicle technique, and as we discussed and described in the section of anatomy, the inferior pedicles take blood supply from the 4th, 5th, and 6th intercostal perforators of the internal thoracic arteries. This is the main blood supply of the inferior pedicle. And as shown in the illustrative picture, the inferior pedicle techniques follow a wise pattern technique, or a wise keyhole pattern technique, and is closed by inverted T-scar. But some tricks in the designing of the inferior pedicle technique, you have to know the most important marking is for the new nipple areola. This should be marked at a position we choose according to the stitches of the patient from 21 to 25 centimeter from the sternal notch. Also, the nipple areola can be reduced in size if it is large, and usually 4.2 or 4.5 centimeters is appropriate for a reduced breast. Also, the pedicle should be 8 centimeter base in smaller reductions and 10 centimeter base in large reductions. The base of the pedicle is very important to consider. Again, in larger reductions, 10 centimeter; in small reductions, 8 centimeter. And again, as we discussed in the chapter of anatomy, the sensation of the nipple areola complex, it's mainly from the 4th lateral intercostal nerve, and we discussed the relations of that nerve. So sensation to the nipple areola complex is usually well preserved as long as there is some preservation of the tissue of the pectoral fascia lateral to the pedicle. When you dissect lateral to the inferior pedicle, you have to preserve some tissue over the pectoralis muscle or the pectoral fascia to preserve the sensation to the nipple areola complex. Okay, so problems with the inferior pedicle technique. The biggest problem with the inferior pedicle technique is the bottoming out. Hanging of the parenchymal tissue downwards with the gravity, because most of the tissue in the inferior pedicle. So bottoming out is the most drawback or pitfalls of the inferior pedicle technique. Number 2, the boxy breasts. Actually, the inferior pedicle, due to presence of the most of the breast tissue in the inferior pool and the difficulty to coning the breast, so result in a boxy breast. Number 3, the lens scars. Actually, the inferior pedicle technique has a pitfall of a lens scar in the inframammary fold. And the modern aesthetic surgery, actually, it drives the surgeons to make a contouring and good results with aesthetically hidden scar and a short scar. The modern aesthetic surgery now it is towards the minimal scar. The last problem with the inferior pedicle is the overriding nipple areola complex. With the larger reductions, actually, and the bottoming out, the nipple areola complex migrates upward, and ultimately you can see your patients after 1 year or 2 years of surgery with overriding nipple areola complex, which is a bad thing in breast reduction, and actually it does need revision surgery.